Okay, you're all set.
Okay. Well, this is a whole new way of doing things, so bear with me. Morning, everyone. Just to introduce myself, and then I'll ask Steve to come and introduce himself. My name is Neil O'Connell. I'm a lecturer in physiotherapy at Brunel University in West London. My interests in terms of teaching are evidence-based practice and teaching students research methods, which is kind of the unwanted stepchild on most clinical courses. Most people come on the courses, they really want to learn how to treat patients, and so they often don't engage so much in the research method side, or if they do, by the time they've had it assessed and they've parked that assessment, they tend to forget all about it. And what we're hoping with the course in the next few days is to try and bring some of that stuff back and improve your skills in sort of reading evidence, using evidence. We're not trying to turn anyone into researchers, it's more about helping people to be a more confident user of evidence so they can better use it to inform their practice. So my research area is chronic pain and assessing effectiveness of interventions for chronic pain. Within that framework, I work with the Cochrane Collaboration. I'm an editor for the Pain Palliative and Supportive Care Group, and I've done some work on clinical guidelines. So I was on the group that developed the recent low back pain guidelines in the UK from NICE, which you may or may not have come across because you guys have just published your own updated guidelines. So there's guidelines everywhere at the moment, which we'll talk about on day 3. So today we're going to focus on the basics of why you need to think about research in your practice anyway. Just some fundamental skills about how you might approach critically reading a paper. Then we're going to talk about clinical trials specifically. We're going to have a few workshops within there where we're going to get you to try and work up a research question. We're going to get you to critically appraise a paper. We're going to get you to calculate some effect sizes, and don't worry about that. It's not as bad as it sounds. And then tomorrow we're going to move on more to observational studies and then systematic reviews and meta-analysis. And on day 3, we're really going to focus down on back pain. And Steve's going to take us through back pain from an epidemiological perspective. I'm going to talk to you a little bit about back pain guidelines, how we do them, what they say, why they might not always say the same thing if you take 3 different guidelines. And then by the end of that, hopefully you'll have learnt lots, or we will have not broken Sarah's computer. So I'm going to hand over to Steve to let him introduce himself, and then Steve's going to take the first lecture of the morning as well.
Cool. Hello, everyone. So I don't know where to look. It feels like I'm looking at myself when I'm looking at the computer. It's weird. So yeah, I'm Steve Kamper. I trained as a physiotherapist and treated patients for a short period of time. After a short period of time, it was decided probably be better if I stopped treating patients and became a researcher. And fortunately, that's going okay so far. So yeah, now I work at the University of Sydney in the School of Public Health there. I do research on musculoskeletal pain generally and spinal pain more specifically in adults and also in children. With a colleague, we also lead something called the Centre for Pain, Health and Lifestyle, where we're really interested in looking at how pain fits into sort of the broader idea of public health. I also do some teaching around research methods and evidence-based practice, and often for clinicians. And I guess one of the things that I often hear from clinicians is this idea of I'm just a clinician, and that's something that you never hear from researchers. I'm just a researcher. You never hear that, and I think it's. That attitude of itself is problematic, because I think it sets up a real division between what goes on clinically and what happens in the research world. And personally, I'm really quite inspired by clinicians who have a desire and who want to engage in research, because most of the time you don't have to if you don't want to. And so in some ways it just makes your life harder. And so as I said, I'm quite inspired by the idea that people want to do things which is more difficult because they think it's a good thing to do. And so that's why I quite enjoy doing this sort of stuff. And at some point as well, there's, I think anyway, a mutual dependency between clinicians and researchers. If we think that from a clinical perspective, research is important, and hopefully over the next half an hour or so, if you're not convinced of that, I'll convince you so. And so there is a dependence then for clinicians, for researchers to be conducting research. There's also a dependence for us as clinical researchers that you guys use the sort of evidence that we're producing. Otherwise, it becomes a sort of academic masturbation. Essentially, if we're just producing research that is not used at all, then there is really no point to doing what we do. So that's about as far as I'll go in terms of background. By the way, if anyone has any questions or wants to stop me or whatever else or ask something, I'm very happy to do that. It's easy in a small group. So yeah, so the first lecture, this is really clinical research and evidence-based practice. Really what's the underpinning of that. But first I'm going to take a step away, even what sits underneath both those things. And this is really about information. And so this is where we're constantly processing information. And we come up with an issue where we have to decide that some information is useful and some information is not useful. And so how do we do that? Mostly it's an unconscious sort of process. And we do it in a couple of ways. First of all, we just kind of give it a sniff and we see, does that sound right? And so that's the sort of first filter that all the information that we're presented with goes through. Secondly, we have a look at who's giving us that information. And we might make a judgment on the information based on where it comes from. And so people we're presented with information, it comes from a certain source, and we look at that source and we try and judge what their motivation for providing that information is. And that helps us decide whether we believe it or not, right? And this is a really important one, right? So all of us are walking around with a specific set of beliefs about all sorts of things. And we filter information based on whether it or how well it aligns with our own beliefs. And this is not something that is just specific to clinical practice or specific to particular individuals. Everyone does this. Everyone's doing this all the time. All of us in the room. And this is really about having a lot of sources of information, and we need to filter that down, and we take some on board and we ditch the rest of it. Sometimes we take notice of information which is not correct. Okay, and this can be due to bias. Essentially, that's getting it wrong. And so I've said this is what bias is for normal people, and that'll become clear to you why I've done that later on. So this is a particular tendency, trend, inclination, feeling, or opinion, especially one that is preconceived or unreasoned. So this is a sort of a stance that we take with respect to some information, which is may not align with the facts. And so what it might be is, for example, a particular type of bias is we might think positively about information from a certain source. So if someone who we think very highly of says something, we're much more likely to believe that. Okay, and this is independent of whether it's wrong or right. Okay, if that person says that, we might believe it. Conversely, if it's someone we don't like, we might not believe it. Similarly, if we have some information which aligns with a certain set of beliefs we have, and religious conviction is one set of beliefs, again, regardless of whether the information is right or wrong, we're more likely to think it's right if it aligns with what we already believe. So, how is this important when we're talking to patients or we have a patient in front of us? So, a clinician with a patient in front of us, you have all sorts of information available to you, which you use to help you make decisions. So, the patient is giving you information, you have your own experience. Some of that you access consciously, and other of it is just, I guess, part of your sort of implicit experience. You have all the education that you went through. Then you're also subject to all the information which is out there in public media, books you've read, the internet, research, friends, colleagues, all this sort of stuff, as I say. So what your job is to take all these sources of information and you filter it down and you prioritize some of it. Okay. But how do you judge that? So how do you judge what information is reliable and therefore information which should be prioritized? And again, this is the way you do it. It's exactly the same. It's no different in the clinic to the way that we filter information when we're out in the world being normal people. So this is where a patient stands in front of you and you're thinking, well, I've seen lots of these patients, right? So why can't I just do what I did last time, right? And so this is this idea that I have the experience, I know what's going to happen, I've done this before, surely that should count for something, right? And it does, but what's important then is understanding how and in what direction that information is likely to be biased. Okay, so again, that initial, so what is it about this sort of information? So what we're talking about here is your memory of previous experience. You've got this patient standing in front of you, you've seen this sort of thing before, you've treated them, something's happened. So what's the issue with just using that information? And there's a couple of issues with it. And first has to do with the patients. Okay, so oftentimes we'll see patients who are in acute stage, something very nasty has happened to them. People who are acute get better, okay? And a couple of days, a couple of weeks after you have something painful happen to you, 9 times out of 10, things are better, regardless of what happens. And when do you see those people? You see them there. So you see them when things are really bad. Even people who are chronic, geez, that's good, isn't it? So people who are chronic, or with chronic pain in particular, you know, it's really hard to draw lines like that. That's the best. It took me a long time to come up with it. It took me a long time to come up with that as well.
I feel your pain.
Regardless of those, so the people who have chronic pain don't have this sort of constant level, right? Things get worse and they get better and they get worse and they get better. They don't come and see you when they're better. They come and see you when they're worse, okay? When they're worse, most of the time, shortly after that, they're better. And that has to do with the nature of symptoms, and it has to do with this whole other set of things as well. So that's one of the reasons why one of the ways that we should filter the information that we have, which is based on our recall of past events. Animation's working well today. The other problem is memory. And people don't remember things very well. Okay? Our memory is not like a video recording of what happened in the past, which is fine, except that most of us are people. And so that means we're the ones that don't remember things very accurately. And what do we remember? Mostly we remember the big things, really good things, really bad things, which by definition are the things which are less likely to occur. So we're much more likely to remember stuff which is less likely than we are stuff which is more likely. And again, the person in front of you is more likely to be representative of something which is more likely than they are of something which is less likely. And so we have this, again, this bias towards remembering stuff which is probably is less likely to be applicable to the person standing in front of us. Another issue is confirmation bias, and this has to do with what I mentioned before, with the beliefs that we have. And the way I like to think about this, so this is this idea that we have certain ideas about ourselves and about the world, and we sort of fit information, or we pay attention to information which confirms that, and we ignore information which doesn't. So I think a nice way to illustrate this is through this little thought experiment. So what I'll get you to do, and I don't ask you to answer this out loud, But I want you to have a think, are you good at your job? So assuming your job is treating patients, do you think you're good at it? Okay. All right. I'm guessing most people are thinking, whether they want to say it out loud or not, is, yeah, I'm pretty good at my job. All right. So how do you think a belief like that would affect these sorts of questions? So if you have this belief that I'm good at my job, and I ask you these sorts of questions, well, do your patients improve? How many of them recovered? How often do you see them? This sort of stuff. If you think that you're good at your job, that's going to affect your recall. Okay? Again, the important thing to note here is this is not about clinicians or about physios. This is about people. This is the way that people work. Okay, so this is not a flaw in yours or my way that we operate. This is a function of all people. It's part of being a human being. So I put this up before. So bias to normal people. So this tendency to pay attention to certain types of information and not. To researchers, sorry. So in practice, how does that work? So what that means is that sometimes we'll believe stuff that isn't true, or we'll overestimate the importance of something, or vice versa. Okay. To researchers, bias means something like that, which is probably completely unhelpful, right? So the sample parameter estimate is systematically different from the population parameter. There's probably not any point actually explaining that, which is a way of saying that I don't know what that means. But essentially, the upshot of that is you do a study and it's not right. Okay, so it's giving you an estimate of effect or an association or something which isn't correct. It's biased in some particular direction. Now, bias is different to error. Okay, so bias and error are different. So when a study is biased, generally it overestimates the treatment effect. Okay, so bias has a particular direction. And so an example there is if the people who are measuring outcome in a study have a particular interest in the study showing a certain thing, then their bias is going to be towards overestimating that effect. Okay, so there's a directional thing. But error is different. Okay, so that's a random variability. It's an imprecision so you might have a measure which is unreliable. So sometimes it's going to be overestimate and sometimes it's going to underestimate. So the bias and error are two different things. And so we reduce bias when we're designing studies by having certain features which try to make sure that we get an estimate of the real effect, an unbiased estimate. To reduce error, we get big samples and we use reliable measures. Okay, so there, as I said, bias and error are different things and we deal with them in different ways when we're looking at research. So this is a bit of an example that we use. Variance, we can, in this case, we can sort of say is synonymous with error. So the top left there, we've got something which is very reliable and it's unbiased. Okay, so the center of the bullseye, that's the truth, and the little blue dots are our estimates from studies. And so you see when you've biased something, you've moved that as estimates into a particular direction. But when you've got something reliable, you've just scattered them all over the place. Okay. All right, a few points about bias. So one of them is bias is a continuum. Things are not biased or unbiased. Okay, things are more likely to be biased or less likely to be biased. And in fact, we can't measure bias in the research world, so we measure the risk of bias. Okay, so again, we're not measuring the risk of it being biased or unbiased. we're measuring how big the risk is that we think it's biased. And because we use these methodological quality features to try and reduce bias, we use them as a marker when we're judging particular studies. And Neil's going to talk a lot more about that in the next lecture. So the reason there is bias in research is because the people involved have a horse in the race. Okay? Researchers generally have an interest in the study showing something. Clinicians who are involved, who are delivering the treatment, usually have an interest in showing something. Often the patients have an interest in it coming out some way. And so this is why we have bias in research. If none of those people were worried about it going one way or the other, we might have error, but we wouldn't have bias. Okay? And I mentioned this before. So the design features, and again, Neil's going to talk about these, and we'll talk about them over the next 2 days, are designed to reduce the risk of bias. And so you can think about the way that a study is designed, or a study itself, is sort of a machine for trying to get at that unbiased estimate. So all those things which go into it, there's a reason for doing it, and that's to try and reduce bias, and that's trying to take out the influence of the fact that all these people have got a horse in the race. All right, so a bit of a change of tack. So why should clinicians engage in research in EBP? So why bother? First of all, it's because it's an expectation. Okay, increasingly in the healthcare system and the professionals within it, the expectation is that you operate within this evidence-based practice paradigm. And oftentimes that will have implications for funding, right? So whether or not you get paid may be tied to whether or not your practice aligns with what research is saying. More importantly though, I think the aim of evidence-based practice is really to formalise how you use information. And it's not just research information, okay? It's obviously information that and so it's a sort of framework for judging the sorts of information that you pay attention to and that you don't. As a particular profession, physiotherapy likes, I should call it physical therapy, shouldn't I? So the profession itself like to say we're based on science. Okay, you don't have to, but that's what the profession wants to do. You can say we're not based on science, and there are different professions which are not, and that's fine as well. But if you want to say we're based on science, then the people who are delivering the therapy have to engage with science. Okay? And this is, I guess, also clinicians and healthcare systems have problems they need to solve. Okay? And they may or may not be able to solve them alone in their clinic. And so science can be used, or research can be used as a tool to try and understand better and to solve those problems. All right. So essentially what we're talking about here, or the way that I'd like to think about EBP, is that this is really about gaining skills to make good judgments about the information that you have in front of you. Okay, so it's information from research, but also by understanding that and the sort of fundamental principles, I think it provides a framework then for judging information from other sources as well. And also we need a job. So you guys should engage with research. Otherwise we become redundant. No one wants to be redundant. So what are we talking about then? So what's EBP? First of all, what is an EBP? Okay, EBP doesn't begin and end with randomized controlled trials, and that's I guess a common criticism of EBP said, yeah, you guys are just all about RCTs. And it really is a straw man. Okay, it's really attacking something which isn't the point, and was never meant to be by the people who sort of came up with the idea. Which is not to say that RCTs aren't important. They provide a particular type of information. And again, Neil will talk more about that later on today. Also, there's sometimes pushback with this idea that EBP will turn you into a sort of a robot or just a technician. Okay, and that's not the case. It will make your job harder. Okay, if you want to do it, because there is a whole new set of skills that you need to learn beyond what you do with patients in order to engage with research and use it properly. Okay, and it's also an ongoing thing. Okay, it not something you learn and stop learning and then go, okay, I'm done now. It's an ongoing sort of thing. It requires that flexibility and ability to keep changing and to keep progressing. Yeah, it won't make the job easier. It will make it harder. All right, so what is EBP? And you've probably seen this, this definition. And I've underlined there the current best evidence, okay, because that may come from a particular type of study. And I think Neil will show you that evidence hierarchy later on. It may be that the best evidence doesn't come from the best type of study, but it's the best available evidence that you have. Okay, and that's what's important about it. And then, as we said, it goes beyond, EBP goes beyond just what's in the research world. And this is not a trivial part of it. Okay, so it's not a trivial exercise to try and understand what the research is saying and then integrate that information with those other sources of information that you have and another source of information as well. Okay, so it's, as I said, that idea that EBP means you become this sort of robot which just delivers whatever the latest RCT says is not consistent with any accepted definition of it. Okay, so this is really about having a source of information which you integrate with these other sources of information as well. And the extent that you do that well is the extent to which you're practicing EBP well. Okay, so a brief history of EBP. So in the 70s in America, there were some doctors and they noticed there was research going on. It looked like this, by the way, America in the 70s. And so there was research going on and there was doctors out there treating their patients. And essentially those two fields existed in isolation from each other. And so there were some doctors going, that seems a bit odd. Why are we doing this? In the 80s in Canada, which looked like this, particularly at McMaster University, some pretty clever people came up with, I guess, a set of ideas and these methods for understanding research as it interacted with practice or potentially. In the 90s in the UK, which looked like this, the Cochrane collaboration came about, and that was really about trying to consolidate information into a form which was accessible for use in practice. Also during this time, the large medical associations decided, okay, this is a way that we want to go, and so they start to get on board with this idea. And they published this sort of series of, and so that's sort of a brief timeline of how this. So I think what's significant about this is it's pretty new. All right, you know, even if we think, okay, this is only really getting some traction professionally, sort of in the 90s. It's not that long ago. Okay, so it's understandable that this is not just going to be like flicking a light switch and we're going to go from one way to another. But what are the alternatives? Okay, so we don't have to use evidence in practice, and medicine went along for a long way without it. And so there's a couple of ways we can do it. And so we can have the old guy and just ask him, and he's a guy. We can treat a heap of patients and just remember what we did with them and remember what happened to them and do the same thing. So this is this idea that I've seen this before. We have biological plausibility, and so this is, I guess, the way that we understand anatomy and physiology, and we can treat based on those sorts of explanations. Ancient wisdom, so if it's been around for a long time, we'll just do that. And so these are all alternatives, and they're all used to greater or lesser extent now and in the past and in different places. And so, yeah, essentially, yeah, this should have come up earlier. So yeah, this is the way that the expert authority works. Everyone stands around and says, oh, I think this should happen. And the next person says, I think this should happen. And then this guy says, actually, this is what's going to happen. Yeah, so what about clinical reasoning? All right, and again, this is this idea that there's this conflict between evidence-based practice and clinical reasoning. So this idea that EBP takes away your need, but also your ability to use your own reasoning in practice. So is it compatible? So what's clinical reasoning involve? Essentially, involves taking a whole heap of information, analysing it, and integrating it from different sources. Where might you get that information from? So I guess to my mind, there really isn't a difference between the fundamental ideas of what evidence-based practice is and clinical reasoning. Clinical reasoning is really just integrating information from different sources, synthesizing it, prioritizing it, which is essentially the same thing that you do, or the same thing that's recommended in evidence-based practice. So how do you do it? So this is, I guess, a sort of, just forget that arrow's there for a second, that's supposed to come later. But so this is this stepped process, and you've probably seen this before. So we ask a question, we do a search, we appraise it, we implement it, we evaluate it. And where expertise and patient preferences fit in with this is in this idea. So you've appraised the information, then you take this other information which you've appraised, you integrate that, and then you deliver it to the patient. So that's the, and we'll come back to this sort of framework again, because I think it offers just a nice way to ground the sorts of things that we're talking about over the next couple of days. So why doesn't it happen already? Okay, seems like a pretty good idea, right? And when you survey clinicians, they all say, yeah, that sounds like a great idea. So why doesn't it happen? And there's this fundamental conflict, right? And researchers are sitting around going, well, you guys can do whatever, you guys think you can do whatever you want, you know? And clinicians are saying, yeah, but you don't really understand patients. And this is a problem, right? No? And I think it's a problem of perception, and it's a problem because researchers and clinicians don't talk to each other enough. And I think it's a lack of understanding on both parties, and to my mind, it's completely unnecessary. Right? This is not a competition as to who's winning, right? So yeah, that's just a view that I have anyway, and I think that I think the solution to it is more things like this. All right, so if you want to be a clinician that engages in EBP, what do you need? I like to think about it in terms of will and skill. All right, so you need that desire to engage with research. So you need to want to do it. If you don't want to do it, it's not going to happen. And you need this set of skills, which is about understanding how research works. And in some ways, I think to an extent, and maybe things are changing now, but we almost set up clinicians to fail in terms of being engaging with evidence, because you can do, and some of you may have this experience, but certainly in Australia, you can do your professional training and really have no good idea about how research works. And if you don't understand how research works, there is no way to practice evidence-based practice. Jeff, could you, sorry, I don't know you. I feel like I'm telling you what to do, and I've never met you before. But could you mute your computer? Thank you. All right. So yeah, as I said, I think we're setting. In some ways, we're kind of set up to fail. We have this expectation that clinicians are going to engage in research, but they're not taught the skills to do that. Okay, and I think there's actually a lot about research that you have to understand in order to be effective in appraising this information. There's a set of skills, but most of them are not that difficult. Okay, they're pretty easy to learn if the will is there. And where we're going to go next is this idea about asking a question. So we're going to start at the beginning. Oh, that's not what I was going to say then. I hate that. So yeah, so these are the sorts of fundamental parts of research that as a clinician you need to understand in order to practice evidence-based practice. And they're not necessarily things which you're going to get taught in your professional training. And as I said, I think that really sets up an unrealistic expectation that clinicians operate in this evidence-based practice paradigm if they don't have the skills to do so. So we're changing that. All right. So how does evidence-based practice and research fit together? To my mind, it all starts with the question. And I bang on about questions a lot because I think it's really important. And I'm going to bang on a bit about it today. So for both researchers and for clinicians, we start out with a question, right? So researcher needs a question to know how to design their study. Then they're going to conduct the study, and then they're going to publish the study. Clinician's got a patient standing in front of them. They've got to answer a question, well, what am I going to do? So what they're going to do is say, what does the research say? And then they're going to integrate these other sources of information. And this is where things line up. Okay? And then we get a treatment decision, gets spat out at the end of it. Okay, so this all starts from a certain alignment of a clinical question. And so that's why this is really fundamental to the process. So I guess going back and thinking about some of the basis of where clinical research start to interact with practice. It's a bit of a historical example. And this was really about epidemiological methods, which are around for a long time, but oftentimes didn't interact with what was going on clinically. And so this is really about quantifying the occurrence and causes of diseases, and this is applying them to questions which were relevant to patient care. And so one of the really famous examples of that was in the 1850s. So they had this cholera epidemic, and lots of people were dying in London, not just because the beer was warm or the weather was terrible or anything like that. But yeah, people were carking it all over the place. Fortunately, Jon Snow came around. People said, nothing, but he knew something. And he got a map of where all the people with cholera lived, the ones that died. And he overlaid then a map of the water pumps around. And what he found was that there's this concentration of people dying around a particular water pump. They took the handle off that pump and less people were dying. And so this was really this a really early application of understanding occurrences of disease and applying it to in a particular situation, which had this sort of big impact on the health of people. London survived. Anyway. So what sort of questions? And there are lots of different types of questions, right? So, and lots of questions which are relevant to practice. So we can talk about questions which of prevalence and of occurrence of diseases and conditions. We can talk about risk factors. We can talk about diagnostic tests, clinical course and prognostic factors, treatment effectiveness, and I group these other things in with treatment effectiveness, measurement properties, experiences and preferences. And these are really different types of questions, okay? And when you have different types of questions, you have a different type of study, okay, which applies. And so if you're looking at ideas of prevalence or questions of prevalence, generally we look at a cross-sectional population survey. If we're looking at risk, we need this longitudinal. We can use a case control study. We'll talk more about this tomorrow. Diagnosis, we use cross-sectional studies. Prognosis, again, we need a longitudinal study. Treatment effectiveness, etc., and it goes on. So again, it's really important to understand the type of question that you have. If you don't understand the type of question it is, you don't know what study you should be looking for. So again, it comes back to this idea that actually how you formulate and understand a question is fundamental to evidence-based practice, because without that understanding, you can't know what sort of study you should be looking for. I'm just going to... Sorry. Good. All right. So just to recap, and I told you I like to bang on about questions, and this is why it's really key. It all starts with the research question, and the reason is, as I said, it drives the design, it drives the analysis, and it drives the interpretation. And so unless you have a really good handle on that, if you're reading a paper and if you can't nail down the question in a sentence, you might as well not read the paper, okay? Because you have no way of appraising whether or not the study's any good, and you have no way of interpreting the results. All right, so what's in a question? So you've probably been told that there's no such thing as a bad question. Well, in the real world, there is, okay? So we're gonna get rid of that. There's lots of bad questions and they're everywhere. So how do we spot a good one? All right, a good research question, it's specific and focused. All right, it's really clear, it's answerable, and it's relevant. Okay, so unless your question is ticking those boxes, it's probably not a good question. If it's not ticking these boxes, the study is probably not worth reading. Okay, because you won't get a clear answer to an unclear question. Okay, if the question is not relevant, why bother with it? If it's not answerable, you're not going to get an answer to it. Okay, so it's really important that you understand what the question is and that you can nail it down and be really clear to yourself. All right, now from a research perspective, this takes a long time. Okay, we start with an idea, but it actually takes quite a period of taking that idea and formulating that into a question. And it's critical for all those reasons. So what does it do? So from a researcher's perspective, it really forces the researcher to clarify what you're thinking and what your hypotheses are. From a reader's perspective, as I said, if it's not clear to you, don't read the study. It establishes the scope of the study. So it tells you the sort of boundaries where this study fits. As I said, it guides the study design. So it tells you who and when to recruit. It tells you how sort of data you need and when you need to collect it, tells you how to analyze the data, tells you how to present the results, and tells you how to interpret and what the conclusions are. And so none of this happens effectively without a good question. So this is kind of a sidelight, and yeah, I apologise for the diversion a little bit, but this is a really a critical point here, and this is about generalisability. And you've probably heard the term samples and populations, and think, well, are there a difference, or are they the same thing? And oftentimes they are used synonymously, but they're different things. And so you have a population, and so that's generally people. It's all the people who fit the definition of your population. So that's everyone who is in a particular area of the world who fit that definition. But you can't do a study on everyone, all right? And so that's where we collect a sample, which is a group of people who are from the population. The idea is that the sample represents the population. So we take that sample out of the population and we do stuff to them and we measure them, and then we get these results. But actually, those results are not that interesting or useful. We're only interested in those results to the extent that they represent what's going on in the population. And that's why we have the sorts of statistical analysis that we use. So what we want to do is we want to take those, because we're not treating the people who are in the sample. We're treating someone from the population who's come to see us after the study's been done. And so the function of the study is to tell us something about the population, not about the sample, and they're slightly different. But it has important implications. So this is this idea of generalizability. So you've got these results from this study. How applicable are they to this person standing in front of me, or group of patients? And there's some key issues. And so this is, one of them is the representativeness of the sample. So this speaks to the idea that the sample is the same as the population in every way, except there's less of them. All right, so as an example, if your population is 60% female and 40% male, your sample should be 6% female and 40% male. If they're of a certain socioeconomic range, then so should your sample be. Okay, so that's the idea of representativeness. So the extent to which your sample is representative of your population speaks to how generalizable those results are. So how applicable the findings of that study are to the patient standing in front of you. And there's lots of things which affect it. Okay, if you recruit from a particular setting, then that may have consequences for the generalizability. Exclusion criteria, obviously, and sample characteristics at baseline really give you a sense, a bit of a snapshot of whether the sample looks like the people who are in front of you. Like bias, generalizability is a continuum. Okay, so there's always a way to say those findings are not applicable to the person in front of me. Okay, nothing is 100% generalizable. And so this is really a judgment as to, is that information from that study, so that piece of information, which are the study findings, to what extent can I apply that? All right, so skipping back to a question. And you've probably seen this, right? So this is PICO, and some people put a T on the end of it. And this is really just a framework for you to conceptualize and nail down the parts of the question. And it's useful particularly for treatment effectiveness questions. And so, as I said, it's really a sort of a framework for understanding it. But as I said, you've probably seen this before. So what's it mean though? So the population or the patient, so remembering this is everyone that you want to represent in your sample. So this is who you're interested in. And the way that you might define that is by a particular condition, but then you might subdivide that at a particular stage. So you might be interested in chronic back pain and not acute back pain, for example. Or you might be interested in back pain which has a certain level of impact on activities, etc. You might be interested in older or younger people or a certain gender. You might be interested in people who do or don't have certain comorbidities. You might be interested in recruiting from a certain setting. And again, as I said, all these decisions you make when you're setting up your question, they have implications for the generalizability of what gets spat out at the end of your study. Okay. The intervention. So this is what treatment you're talking about, and it defines the scope of it. Okay, so if you're thinking about a manual therapy intervention, what's included and what's not? Is there something around the dose? Is it something about the type? Do you confine the intervention to a certain protocol, or do you just set some broad parameters and let the person treating decide within those parameters what to do? Again, this subtly changes the exact question that you're answering. And you might consider co-interventions. Okay, are you allowed to have them? Are you not? Are you going to constrain them? Are you going to leave it open? Control or comparison, and this is really important. So when we're talking about treatment effectiveness, we're always talking about relative effectiveness. Okay, there's no such thing as treatment effectiveness on its own. It's always compared to something. That something might be nothing, but it's still compared to something. And the reason we need to define our control or a comparison is to answer this question, as compared to what? So when we're talking about treatment effectiveness, what are we comparing it to? And we can think about all sorts of different, we could think about nothing, a waiting list, a placebo, usual care, other treatment, etc. This is critical though. It's really important to nail this down because they're completely different questions. All right, so if we're thinking about a single group, we might be inclined to say that this treatment is that effective if we don't compare it to anything. All right, but if we decide that we're going to compare it to a waiting list, we probably decide it's only that effective. If we compare it to a placebo, we might decide it's only that effective. If we compare it to usual care, it might be only that effective. So you see, if we're talking about treatment effectiveness, that measure, i.e. the size of that green line, obviously depends on what you compare it to. So there is no treatment effectiveness on its own. And the way that you define your control determines what question you're answering. And so you need to decide up front what question you're interested in. And there's good reasons for choosing any of those, but they are different questions fundamentally. And so that, again, this comes back to understanding what question you're trying to answer with the study that you set up. And conversely, when you're reading a study, what question have the researchers decided that they want to try and answer? Outcome. So how will you know if there's been a change? And you can measure symptoms, you can measure function, you can measure just about anything you like. All right, I'm going to talk a little bit about measurement in a bit. So how should it be measured? You have to make these decisions about how you measure it. And again, we'll come back to all this idea of measurement later because that's another thing I like and talk more about it. And when should it be measured? So again, these are all issues that you need to define at the point that you're setting up your study. All right, time for me to stop talking. So we're going to do something. You guys are going to define a research question using PICO, so it's going to be a treatment effectiveness question. And so, well, it's going to be a treatment effectiveness question, so you don't get to decide which type it is. But yeah, so you're just going to run through those PICO components. So once you do it in a group, and have a bit of a discussion about it. And it's probably most useful for you if you think about a patient that you've had or that you have, and think about if you are going to set up a study which answers a particular question that you're interested in, how would you define your question? So how are we going to do this?
People talk to each other on there.
Yeah.
So that's one group.
Mm-hmm.
And this is a group.
Well, we've only got.
Jeff and Jessica. Jamie had to go to work.
Okay.
Okay, so Jessica and Jeff, if you guys want to unmute yourselves, and I'll stop recording. For now, we'll turn it back on. But you guys can unmute yourselves and talk about the question, if that's cool, yeah? Like, thumbs up. You can unmute yourself now, Jeff.
Hey, Sarah, I'm